Okay, so Thursday, October 22nd, we're going to go through the muscle unit 7 portfolio assignment and see if there are any questions or concerns. There were a handful of identification items. So anyway, there are some the definitions, of course. I don't think any of you ever really struggle with those, but I did want to pull up some of the illustrations from visible body or images and make sure that you guys are okay with those. Letter A is pointing to potentially a couple of items. You could have just frontalis muscle. We also called the complete muscle the occipital frontalis. We also know it as the epicranius, and of course we discussed that it raises the eyebrows. And then B is pointing to the temporalis. Actually, it's pointing to there's a little bit of fascia over the top of it, but it is pointing to the temporalis muscle. And then you've got the orbicularis oculi, and then one of the zygomaticus muscles. You don't necessarily have to specify major or minor. Zygomaticus is fine. Then you have the orbicularis oris, and then one of our chewing muscles, the masseter, and then this neck muscle that goes from the sternum and clavicle up to the mastoid, we said was the sternocleidomastoid. And then that sheet muscle, the flat muscle, we called the platysma. And then, and again, with functions, you can be as descript as you want to be. You can put one, because some muscles like the trapezius they have multiple actions. You can list all of them. You can just put one. It's totally up to you. Try to get the muscle name correct though. Trapezius in the upper shoulder area, kind of a diamond or kite shaped muscle. B is pointing to the infraspinatus. We can see the spine of the scapula here, and then pointing to the underneath area, the infra area of the scapula. So that's the infraspinatus. And then we've got a large, chunky muscle. It's not one of the rotator cuffs, but it is a teres muscle. That's the teres major. And then we've got this big back muscle, kind of the middle and lower back cape, we call the latissimus dorsi. And then we've got our two of our three gluteal muscles. The one in the hip area we call the medius, and then the large one in the posterior region, the gluteus maximus. And then we move down to this section. We can see the deltoid for letter A, and then the pectoralis major, of course, pointing to letter B. Now, letter C is a little bit tricky. I'm going for intercostals, so either one. It looks to be more external. It doesn't have the externals removed, but if you just have intercostal muscles, that would be fine. We also see they're kind of nestled in there. They don't really show them, but they're called the serratus muscles, kind of that serrated edge muscle that we oftentimes see kind of under the armpit and the lateral aspect of the thoracic cage. But anyhow, I would go with intercostals for that one. And then we've got the biceps brachii. Letter E, that's not correct. That's going to be the letter E is pointing to the external obliques. My secretary is going to have to have a little talk. That's me, by the way. External oblique, I'll take off the S. External oblique muscles, and those are going to have to do with trunk rotation. Okay. So anyhow, letter E, those are the external obliques. Okay. And then letter F, you're going to have the rectus abdominis. And letter G, that is going to be the internal obliques. So double whammy. Must have been tired that night, or else I was looking at something else. Probably multitasking. See, multitasking is good. It saves time, but sometimes it comes back to get you. But anyway, we'll do trunk rotation for that one too. Okay, so external, you can see the fibers, the external oblique, and then we remove that, and then we have the internal obliques. And then if we remove that, we would see the transverse abdominis. And then for letter H, you could just have the flexor group. Remember the anterior aspect of the forearm. I just need you to know that they're the flexor group. So if they're the front of the forearm, they're going to flex the wrist. And then we had this brachioradialis, the hammer muscle that we talked about as well a little bit last week. Okay, now we're going to look at the kind of the posterior aspect. We could see the triceps brachii. This is back view, front view. Then we could see the biceps brachii, and then kind of sandwiched in between, we're going to find that brachialis muscle. And then we've got a front view. We can also see the biceps brachii there. And then again for letter D, just like we saw above, that's going to be that brachioradialis. We had that for letter I. And then again, letter F, or letter E, you're going to have the extensor group, and letter F, the flexor group. Again, you don't need to be specific with these. Just know the posterior forearm muscles generally get grouped as being extensors. The anterior forearm groups generally get linked as being flexors. All right, we'll travel down into the hip area. We've got the TFL right away, that tensor fascia lata muscle, and then heading right down the center, one of the quadriceps, we see the rectus femoris. And then just a little bit medial, we have the medialis, and then a little bit lateral, we have the lateralis. So these are your two vastus muscles. The third one is going to be located underneath. And so over here, we've kind of removed some of this. So letter I is going to show us that vastus intermedius. So inter means between, medius down the middle. So vastus medialis, lateralis, and then intermedius underneath. Letter H is that talar muscle we called the sartorius. And then F and G, you could combine these as far as I'm concerned and call these both the adductor group. Again, I don't need you to be specific with these. If you just know that we're dealing with the adductor group, they also call them the groin group. That's perfectly fine. And then letter E, we've got the front of the shin, what we call the tibialis anterior. And then we look at a posterior view, and we've got the gluteus maximus again from earlier, and then we've got our three hamstring muscles. The larger and more lateral is going to be the biceps muscle, so we call this the biceps femoris. Okay. So biceps femoris, we're going to get flexion of the leg. Flex his leg. I don't know what happened to an extension of the thigh. This whole group, we wouldn't have a back group extend the thigh. Okay, so the biceps femoris, letter B, is going to be kind of the biceps of the lower leg. Okay, that's going to extend the thigh. So that means the whole thigh will go back, but it's going to flex the leg primarily. I think maybe more specifically, we could put flexes the knee for that one. Your leg is that's a big area. Okay, so when you bend your knee, you're going to use the hamstrings to do that. Okay, so you have the biceps femoris, semimembranosus, semitendinosus down the middle, and then the membranosus is going to be the most medial. So that's one way to remember that one. Membranosus has a lot of M's in it, and medial has the M in it. So membranosus is most medial. Okay, and then letter E, we removed the calf muscle, so we have the soleus, and then letter F is the gastrocnemius. Okay, so those are the main identifiers that I was looking for those muscles. You guys didn't have to do anything with M lines or H lines. I believe you had this one, letter E we'll start with. That's the epimysium. And it's also continuous with a tendon and as well as fascia. And then we work kind of working backwards. Remember, we've got the belly of the muscle, and then we have all these fascicles. So letter F, kind of hidden down here, that's circling a fascicle. Okay. And then letter D, we pull out one of these bundles from the fascicle, whoop, and that's what letter D is showing. That's going to be a muscle cell or a muscle fiber. Then we get even smaller, we get the fibril. And then we finally get down to the filament level. So we do see a thick filament and a thin filament. Again, this semester, the WIDS really only wants you to know from fascicle on up. They only want you to know the tissue layer. But I think knowing that a muscle fiber is a muscle cell for now is good for you to know. And then next semester we get into a lot more detail. We basically break this whole area down even further and analyze how a muscle contracts. Okay. So that's pretty much it. I did have one thing I wanted to stop at the end here. There were a couple questions on Paul, and Paul talks about Paul having hormone therapy for his cancer. It decreases the testosterone levels in the body. It asks if radiation was the cause of his muscle pain. Probably not. Hormone therapy and radiation are not the same. Of course, the hormone therapy that he's on specifically is to decrease muscle mass, or it could cause a decrease in muscle mass and an increase in body fat. So by that way, the hormone therapy is probably more likely the cause for Paul's pains. So anyway, his muscles are, testosterone builds muscle, and Paul's hormone therapy is to decrease testosterone. So we would probably see a lower, his muscle mass would be decreasing or going lower. So, should Paul rest his muscles, try to rebuild his muscle mass? Probably didn't give him the best advice. Rest is good. We actually do want Paul walking around a little bit. We know that calcium and Wolff's Law and bones and muscles working together can help to kind of stimulate some of that growth. Because naturally the hormone therapy is decreasing the mass. If we can get him doing being active, he might, in stretching as well, we might see his pain issues subside as well. So anyway, that was that. I am going to go back to there we go. Okay, now I want to go through just a couple of items with the central. So anyway, that's the muscle portfolio before I just jump right into the next item. That's due next Tuesday by the end of the day. Again, if you need more time, that's perfectly fine. But hopefully you've got a little bit better understanding. If you haven't started it already, this will get you going and motivate you to get that completed. In the meantime, again, keep working on your Padlets, keep working on your exams, your exam reviews. I wanted to emphasize, that's why I had this open. Again, it's important that you refer to these exam review questions. They're going to open up into, I'll just open, many of you are probably getting ready to do exam 6. So before you do, and again, maybe even before you start getting too deep into each unit, you may want to print these off at the beginning of each unit as opposed to at the end. But anyhow, let me move my little picture out of the way. You can download it from here as a Word doc. It's, you can open it with Google Docs, however you want to do it. But I would print these off and at the beginning of each unit and spend some time while you're studying and while you're doing your portfolios. A lot of these are definition related. So if you're doing definitions already for your portfolios and you're looking at your Padlet videos, have this out and be, kind of working on that. I can't stress enough. These are the exam questions from the exam pool. Okay? These are the pool questions. So when you click open exam, you're going to get 40 questions from this pool. Well, if you've spent a couple of weeks working on your unit, and you've been kind of filling this out as you go, and when you get to some that maybe you're unsure what they are, you shoot me an email or ask me, or in class, however you want to do it. But you can effectively fill out the key to the pool. And then once you're ready to take the exam, you'll have already seen the questions. You already know what's going on, and it's not a big surprise, and you're not going to be fooled by any questions that don't make sense, because hopefully before you take the exam, you've already isolated questions in your review from the pool that don't make sense and that you need extra help with, or that you need to go further with. So if you do see it when you go to take your exam, you're going to be prepared. So I can't stress that enough. So please do that. And right now you have the review questions for exam 7. Hey, I would today, I would print these babies off, or maybe you're not a printer kind of person, and which is fine too. We've got a little bungle there with that first one. Again, like I say, sometimes Google Docs or Word into Google Docs, PowerPoint into Google Docs. Sometimes you end up with weird stuff like this. So I think it's pretty evident what well, I'll just undo all that. But anyway, I think you could figure out what's going on with that first one. I don't think any more of them are like that. So something happened, with the formatting, I'm assuming. So anyway, yeah, if you go through, this is going to be endocrine system. Starts with central nervous system questions, and then has some endocrine system. So what we did on Tuesday, what we're going to do a little bit with today, we'll continue with on Tuesday. That pretty much will cover everything in exam 7. So I would print this off now and go through as you're doing your portfolios for unit 7. Maybe print off exam 8 review while you're at it. But anyway, get that going, and by the time you're ready to take the exam, you're set. Okay. I know. I hope you guys are all doing that. I don't know if you are. That's why they're there. I'm assuming you are, because the exam scores are very good, and I'm not receiving too many questions, comments, or concerns about the exam and the questions. I do want to say though that once you finish taking it, first of all, you have unlimited attempts. You know this, and it keeps your highest grade. You know that, and it's also, they're all open until December 10th or 11th, right around there. You know that as well. But I do want to say that after you take it, it's going to show you the results, the ones you missed, the ones you got correct. And so when you go back and you see the ones, you look at the ones you missed before you close out of it, and if you're certain that you got it right but it marked it wrong, please email me and let me know. I enter these exams in. The key isn't all, I am not perfect, as all of you know that for sure. But anyway, there could be some that I've put B instead of C. It's not likely, but it is possible. So it seems like every semester there's one or two questions that for whatever reason the key was wrong. Well, whatever the reasons, you're looking at the reason. But I can go back in and fix it. So if you do notice one that was marked wrong and you're really positive that the test is wrong, and I'm not saying that's going to be the case, but I am saying that it could be the case. So be aware of that. We learn from our mistakes, right? Too. I'm not saying I'm making mistakes, but I do. But anyway, at the bottom, when you get your results, Look at the ones that were incorrect and try to determine why they are incorrect. And because the old cliche of learning from your mistakes is true, especially if you decide to go back in and redo the exam, take it in that you might see those questions again that you missed. So you won't miss them a second time. All right. So anyway, maybe you will and learn from your mistake again. And we don't call them mistakes, though. That's not. We call them learning opportunities. So at the end of every exam, you'll have some learning opportunities potentially in front of you. Anyway, so I think you get the drift. So don't forget about those, and don't forget about maybe printing them off. At the beginning of a unit, kind of go through them as you go. So I want to discuss just a couple of items. I don't want to keep you guys very long today, um, but I do want to go through a little bit with the central nervous system. This is kind of concluding part one of Unit 7. Unit 7, part one is endocrine system and central nervous system. We're not going to get through all of it today. I do just want to introduce you to a couple of the items. Next Tuesday, we're going to basically pick right up where we leave off today, discussing more with central nervous system. And then we're going to transition into part two, or Unit 7B, whatever you want to call it, where we're going to look at the peripheral nervous system. In essence, we're going to look at nerves. And then we're going to look at a little bit of the physiology, not a lot, but a little bit of the divisions of the nervous system, of the peripheral nervous system. So we're going to go and look at what we call the autonomic nervous system. We'll talk a little bit about stress, sympathetic nervous system versus kind of calm, relax, homeostasis, which is the parasympathetic. We'll talk a little bit about those processes as well in part two of Unit 7. So anyway, I do want to introduce you a little. We do have a little bit of time today. I do want to introduce you to the central nervous system and a couple of the key features. Next Thursday, so anyway, and then Tuesday we'll finish this. We'll get into the peripheral nervous system a little bit, talk about nerves, and then next Thursday we're going to look a little bit more at the visible body. I want to pull up a couple of items with that. I want to take you through a little more visuals with the visible body. I may have you kind of work in groups, or kind of I may have you do a couple of things on Thursday with your Unit 7 portfolios, or with some of the visible body. Anyway, so stay tuned. You'll know what happens when you get here next Thursday. So it's not going to be anything, painful, or it's just maybe different. In fact, it might be much less painful than having to listen to me the whole time and look at what's going on. So you'll have some maybe a little bit different opportunities next Thursday. I don't know. We'll see what happens. For now, I do want to talk about the central nervous system. Uh, as we dive into the nervous system, there are a few items we've discussed already. Right, we've looked at a neuron, we've looked at axons a little bit, and dendrites. So next week, on Thursday, I'm going to spend some time pulling up, like I said, visible body. At that point, I want to look at some of the cellular stuff. I want to look at some of the nervous system tissue stuff, and then go a little bit deeper and kind of review what we just did with central nervous system today and Tuesday. We'll look at some the awesome brain images that are in visible body. So again, we're going to kind of introduce you to some of the structures today and Tuesday, and then on Thursday I'm going to visible body it up. I just found out, and I don't know if I can, if I'll be able to do this, if it's compatible, but in Zoom, I can, obviously I'm sharing my screen. You can also share your iPad to the screen. And so I have the visible body app on my iPad, and I tried testing it out yesterday, sharing my iPad screen and visible body to the Zoom screen, and I got an error message. from IT and my so anyway, I'm trying to figure out. I'm hoping they downloaded or put whatever they needed to do remotely on my computer. So anyway, the visible body experience, because right, it's been so glitchy. That's why I've been kind of avoiding it a little bit and just hoping that you guys are working on it as well. But I really love it, and I really look forward to using it more as a live tool in our sessions. So my hope is that, and goal is that by next Thursday, my tablet and Zoom will be compatible, and you'll get a much better experience with the visible body while we're in class talking about it, because it is a little bit different when you're doing it on your own at home and looking at different things. And I don't know, maybe you, I don't know. So it may be a little bit more helpful. I know it will be more helpful if we can do it together. But again, we got to get the electronics and the tech worked out. Anyhow, a couple of things with this, with the central nervous system. We are really talking about two things, right? Two structures. We're just talking about the brain and the spinal cord. So we're going to start by looking at the coverings, and we've looked at this a little bit for all the way back in week 1, right? We saw the different body cavities, we saw the cranial cavity and the spinal cavity. So we also mentioned that there are some layers that are involved in kind of the structural integrity of the brain and spinal cord, regarding protection especially. So we do have a couple of protective coverings of the brain and spinal cord, and of course we know bone is the primary covering. Yeah, so we've looked at the cranial bones and some of the different structural features of the cranial bones that are there to kind of accommodate the structures of the brain. So we saw that sella turcica. We saw it on Tuesday too of this week when we looked at the pituitary gland. But we know that the foramen magnum of the occipital is another bony landmark that helps to accommodate the needs of the brain and spinal cord. So bone is a covering of the brain and spinal cord. So your vertebral column, of course, then for spinal cord. And then underneath the bone, or deep to the bone, we do have 3 layers of tissue. We call those meninges. Some of you have probably heard of meningitis at some point. So that's an inflammatory condition, typically due to some sort of an infection. Could be due to, there are other factors involved as well that are possible, but the meninges of the spinal cord and brain could be inflamed for some reason. So we would have to perform maybe like a lumbar puncture or a spinal tap to withdraw some of the fluid that we'll talk about that specifically. That fluid has a name, so we'll talk about that as well. They're not pulling blood out when they do a spinal tap. Okay, so we look at these coverings, and first, one thing we notice right away with the brain, so we're looking at a coronal section or a frontal section. We can see the brain tissue is lighter on the inside and darker on the outside. So we call this white matter and gray matter. And the brain, generally, we would see white matter surrounded by gray matter. So keep that in mind. We'll see that in more detail as we go. We're going to work our way from deep within to superficial. Okay, so when we look at the deeper aspects of the cerebrum, or of the brain, we can see there's some kind of webbing going on here. Well, right up against the brain tissue itself, you can kind of see this white layer representing what we call pia mater. By the way, the 3 meninges. So you do need to know. So structurally, what do we need to know from central nervous system? Right off the bat, we need to know the names of the 3 meninges that cover the brain and spinal cord. And you need to know them from either superficial to deep or deep to superficial. We'll do both. We're going to go deep to superficial, and then we'll go back in just to kind of to review them. But you need to know these three meninges, or these three layers or coverings of the brain and spinal cord. All three end with mater, mater, like an alma mater, right? Of a college where you went to college. Hey, mater means mother in Latin. So this first layer that's going to be right up against the brain tissue is called the pia, P-I-A, mater. Pia means soft. So this is a soft mother, a soft covering right up against the brain. And then we have a little bit of a space above that pia mater. We can see all of this webbing in there, and that space they call the subarachnoid. So this looks like a long word. It looks like subarachnoid. So yeah, we want to break that down to be sub, okay, sub, and then arachnoid, kind of like a spider, right? Arachnophobia. So arachnids are spiders. So subarachnoid must have something to do with below the spider, below the something, right? Space. Well, so we'll get to that in just a second, what the arachnoid is that they're talking about. But we know that we are in a space there, and that space has a webbing. So the layer of that creates kind of the roof of that subarachnoid space is then, of course, the arachnoid mater. So, of course, meaning sub is below. So below the arachnoid. Okay, so arachnoid must be just above or superficial to the subarachnoid space. Okay, so that's your second layer of tissue, or your second meninge is arachnoid mater. Okay, so we have pia mater, then a space, then arachnoid mater. This subarachnoid space is going to come up again in just a few minutes when we talk about that fluid that's circulating around the brain, within the brain, around the spinal cord, and even inside and through the spinal cord. That fluid is going to travel, and part of how we do the lumbar puncture to draw that fluid out, we have to go into the subarachnoid space. That's where this fluid I'm talking about is one of its circulatory pathways, one of its routes is going to be contained within the subarachnoid space. Okay, so you have pia mater, arachnoid mater, and then we get another space. Okay, we call it the subdural space. You can see that over here, subdural space. So if subarachnoid was under the arachnoid mater, subdural must be under the dura mater. So the outermost layer we call the dura mater. Okay, dura means tough, right? Like durable. Okay, so the most superficial layer is called the dura mater. Okay. So we've got dura mater just about kind of connected with that, with the skull, right? With the the kind of the underside of the skull. We do have what's called an epidural space. I bet all of you have heard of an epidural at some point. We typically think about it when we're dealing with pregnancy, right? And childbirth, birth and delivery. An epidural is going to be in the epidural space, so upon the dura. So we're going to be even higher. They don't really show the epidural space here. We typically see that in more detail when we look at the spinal cord and then these same meninges around the spinal cord. Okay, so again, working from superficial to deep now, we have the most superficial layer called the dura mater, and then the next layer called arachnoid mater, and then the innermost layer called pia mater. okay, which means soft. So soft mother, spider mother, and tough mother. All right. Yeah, that's what those are the meninge layers. And then the spaces then of course are subarachnoid space underneath the arachnoid mater, subdural underneath the dura mater, and then we'll also see the epidural space later on. Okay. We have what are called ventricles in the brain. Okay, so we have some spaces, we have some sinuses as well. The flow of that fluid is going to pass both within and around the spinal cord and brain. Okay, so the meninges, the three membranous layers, again, dura mater. We're not worried about this. This is too. This information is for a more advanced understanding of structure. If you guys can walk out of general E&P etched into your long-term memories that there are three meninges that cover the brain and spinal cord, and from superficial to deep, they are the dura mater, the arachnoid mater, and then the soft innermost pia mater. If you can have those three down as you walk out of general A&P, man, awesome. That is good. Okay, don't worry about some of the other deeper minutia. Okay, arachnoid mater, pia mater, like the sinuses, we're not going to worry about those right now. Okay. The spaces, we did talk about these spaces, right? The epidural space just above or superior or superficial to, I should say not superior, superficial to the dura mater, and then the subdural space between the dura and arachnoid. And then, of course, the subarachnoid space. And that takes us to that fluid I mentioned earlier that's flowing through that subarachnoid space called the cerebro meaning cerebrum or the brain, and then spinal meaning spinal cord. So we do have a cerebrospinal fluid, which is CSF, the abbreviation. And again, that's going to provide a functional kind of a supportive cushion for the brain and spinal. So in essence, our brain and spinal cords are kind of floating this fluid, which is nice. We don't want the inside of the skull and then the brain to be right up against it. We want the brain to kind of be floating a little bit inside of the cranial cavity. A concussion occurs when the brain kind of passes through these that safety barrier, these meninges, and that fluid, and it kind of makes contact with the inside of the skull. And there are different degrees of concussions depending on the degree of how hard the brain made contact with and how much of the brain made contact with. We used to think with concussions that it was just, one really good concussion can lead to long-term issues. That's true. Certainly can, right? Maybe even a couple, of pretty good concussions, can lead to some long-term issues. What we did not know up until probably the last, many of you maybe heard of CTE. This is a little bit different than just one or two concussions leading to brain damage and behavioral issues down the road. CTE involves more kind of micro concussions. So small concussive forces, a lot of them built up over several years, can lead to long-term uh, uh, cognitive abilities, behavioral abilities, memory loss, um, a whole slew of items. So anyway, CTE. This is concussive, chronic, traumatic, encephalopathy. So chronic meaning it's happening, traumatic meaning there's chronic trauma, and that's caused the brain basically to have pathologies with it. So Okay. So those fluid spaces that the CSF travels through are again both around the brain in that subarachnoid space and spinal cord. We also find them within the brain in some of the different cavities, ventricles, and canals of the spinal cord. Ventricles, we'll see this term again, especially when we discuss the heart. We get to cardiovascular. A ventricle is basically kind of like a room or a space. So we do have four ventricles within the brain, or four spaces within the brain. This is where cerebral spinal fluid kind of originates and comes back home to and cycles through the brain. We have a couple of lateral kind of ventricles. We can kind of we look at a frontal view, or we look at a superior view. You can see these large lateral horns and lateral ventricles. Again, these are spaces within the brain. When we travel a little more midline, we end up in what we call the third ventricle, and then we go a little bit deeper into kind of around what we would call the brain stem area. We're starting to see then the fourth ventricle, and then we also can find down through the center of the spinal cord is a central canal. So pretty cool. Yeah, there's a fluid filled group of rooms within the brain called ventricles that produce and cycle cerebral spinal fluid through. And then, of course, in that subarachnoid space, traveling around the brain and around the spinal cord, that's another pathway of cerebral spinal fluid flow. So, I'm not going to spend a lot of time on cerebral spinal fluid. These two slides discuss the circulation and flow of CSF. I think it's important that maybe choroid plexus is a term maybe that you should probably associate with cerebral spinal fluid and the ventricles of the brain. And again, know that there are four ventricles as well. The specific names, again, I would say no. It's good if you guys walk out of here, again, know the three meninges and the spaces with and around those meninges, know cerebrospinal fluid and ventricles as well. Beyond that, specifics of the brain itself, we'll get into that in a little bit. I do want to, probably on Tuesday, I don't know how much we'll get into today. I do just want to go through, at least get us through the structures of the spinal cord, and then we'll go from there. Again, so we're going to do spinal cord and then go up to the brain. So far, so good. Doing the coverings first. Now we're going to do the spinal cord. The spinal cord, of course, lies within the spinal cavity, extending inferiorly through the occipital bone, through that foramen magnum, and terminating right around the first lumbar vertebra, right around the area where they would maybe do an epidural or a lumbar puncture. We do see a couple of kind of bulges or larger kind of areas in the cervical and lumbar regions of the spinal cord. So we'll look at those as well. Now, the spinal cord itself does end right around your L1 lumbar, but remember, all of those lumbar vertebrae still have vertebral foramen. So we do see some extensions or tails off of the spinal cord in the form of nerve. We will look at that in more detail when we get to the peripheral nervous system. Remember, central nervous is just brain and spinal cord. Peripheral is all of the nerves that come off of the brain and spinal cord. The other things we see with the spinal cord, other than just generally it being located and contained within the spinal cavity, we do have what are called nerve roots coming off of the spinal cord. These nerve roots are going to be what attach to and ultimately become the peripheral nervous system, or your nerves. Now, the thing about nerves, and we know this from all the way back to week 1, nerves operate in a sensory coming in pathway, right? Sensory comes in, motor goes out. So we have two separate nerve pathways. Okay, that's very important to understand today. It's important to understand in the future. Okay, but definitely understand as we segue into what these nerve roots are, as we keep going within the nervous system and really start uncovering not just some of its structural features, but look at some of the basic functional aspects. We're going to see again that we have sensory coming in, motor going out. Okay. And so that comes into play right here with these nerve roots. So the dorsal nerve root. So we have a pathway of nerves that's going to kind of come into the spinal cord, into the back door. So remember, dorsal means back or behind. So the back door or the back entry into the spinal cord we call the dorsal nerve root. That's going to be where the sensory neurons are going to be located. Unipolar. So unipolar means we've got one pole. In other words, I touch something hot, I need that stimulus transmitted extremely fast to the spinal cord. And that transmission is going to be on one pole, going to head straight through the back door and the dorsal root of whatever spinal nerve the stimulus comes in from. And then we travel and send that impulse up the elevator, what we call ascending tracts. So we'll see ascending tracts in the spinal cord. These are basically elevators that take the sensory signal up to the brain. Okay, so again, sensory comes into the back, dorsal, and then goes up the elevator in what we call an ascending tract with a T. We'll look at that in a few minutes. Then if I need a motor response, right, I touch something hot. There it is. Ow, I need to pull my hand away. Okay, so the signal that comes out to get my shoulder muscles, my arm muscles, my finger muscles, my back muscles, to get everything to do this action, that's a motor aspect of the nervous system. So the response, the motor response, is going to come out the front door, what we call the ventral nerve root. These are going to be multipolar. And don't worry about unipolar, multipolar for right now. Just know that motor comes out the front door and travels to your muscles to get your muscles to work. So sensory comes in, goes up to the brain, motor goes down in a descending elevator and heads out the front door to get your muscles to work. So sensory dorsal, motor ventral. Okay, sensory in the back, motor out the front. Okay. We do have what are called interneurons as well when we look at the spinal cord. Not only when we, by the way, too, we'll see that the spinal cord, there we go. We'll see that the spinal cord is kind of surrounded with white matter. We call this myelin. So we'll look at myelin in a little bit more detail next week. But myelin is simply just like an insulator. We've looked at glial cells. Remember the two types of cells in nervous tissue were neurons and glial cells. So glial cells oftentimes are the glue cells that produce some sort of insulator. So we see that the spinal cord is insulated with white matter, and then we can see some gray matter on the inside here. Okay. Okay, this is the anterior and the posterior aspects. Okay, so we'll look at this in more detail in just a second. I want to go back to here. Okay, so structure of the spinal cord again, and so neurons, sensory comes in, motor goes out. Now, occasionally, oh, that's what I was talking about, interneuron. Let me go back here. So in this little gray area, we oftentimes will have what's called an interneuron. So if sensory comes in, goes up the tract, motor comes down, heads out the front door. There are times when that amount of need for the brain involvement may not be necessary. I may need something faster. Like if I do touch something really hot or really sharp, the sensory certainly is going to come to the spinal cord and it's going to go up to the brain because you know that it's hot. But before you even sometimes like feel it in here and store it, your body's already pulling away. So we have a special feature called an interneuron, where when that stimulus comes to the spinal cord and it's really loud, it's really high frequency, it's really screaming because whatever you touched was so intense. If that comes in hot like that, we don't necessarily need to go ask the brain if it's okay to move the arm away. We have a specialized interneuron that'll get that signal and it'll shoot a transmission of impulse directly over to the motor nerve pathway to elicit a response to start happening even before the signal has reached the brain and the brain can even think about it. We see this oftentimes. We call this like instinctual or reactions. We see this with athletes that oftentimes are able to sense and respond to stimuli before before the message is even able to be computed in the cerebrum of the brain. So again, these interneurons they're gonna allow for that. They're a bridge to kind of avoid having to use the elevator exclusively to get the brain involved. Now, is sensory going to go to the brain under those conditions? Well, absolutely, but we don't necessarily have to wait on the brain to tell the motor neurons what to do. We have an interneuron that can enable that to happen. Okay, so so spinal nerves all coming in and having these dorsal uh, roots for sensory and ventral roots for motor. We have this last bullet here. It says cauda equina. Caudal has to do with a tail, and equina, of course, has to do with equine, right? Like horses. So we do have what's called a horse's tail that we'll look at in more detail next week when we get into the peripheral nervous system. So the cauda equina, that's the end. So as the spinal cord kind of terminates at that L1 area, we do see it kind of fan out into what we call the horse's tail or the cauda equina. Gray matter and white matter. We just saw gray matter for spinal cord is going to be the innermost or the deepest aspect. And again, it does kind of look like the letter H, and it does have little kind of limbs that come off and called horns. We see the posterior columns or the gray horns. They have the little crossbar they call the gray commissure. Again, that's getting into some pretty detailed microanatomy of something that I think for now it's important that you just grasp that the spinal cord is white matter on the outside, gray matter on the inside. Okay, if you can get that, you're good to go. And it does again, it does kind of look like a letter H. Okay, and then again, the white matter that's going to be surrounding the gray matter. This is going to be kind of the insulator. It's indicative of myelin, one of the kind of fatty insulators that we need to speed transmission of impulses. Okay, and so the function of so why do you have a spinal cord? What is the function? I think it at this point, hopefully, it's pretty evident that the spinal cord is basically a relay station. So we bring sensory to the spinal cord. It relays that information to the brain. The brain has some ideas. Sometimes the brain doesn't have to think, right? We have automatic responses. So we send those automatic responses or those more somatic conscious responses from the brain back down the spinal cord to elicit some sort of response. So the spinal cord is a conduit. It's a relay station. It's a hub of activity for again basically transmitting and moving signals along. Right. We move sensory signals along the ascending pathway to get them up to the brain. We move motor signals along the descending pathways to get some sort of a response. So um, what do you need to know specifics regarding the names of these tracts? So we see the word tract. Now, this may be one of the first times we've seen it. I think we've possibly seen it before, maybe in week one, but we're going to see this term tract with a T come up quite a bit, especially when we get to the digestive system and the urinary system and the respiratory system. We're going to see the word tract, and a tract is in essence kind of like a pathway. It's a network of tunnels, network of tubes, a network of some sort of a pipeline. So that's what a tract is. So it's a way of getting something from point A to point B. We have a tract, and oftentimes a tract we'll see later on. It could be a hollow tract. Usually, it's going to be made of epithelial lining and some smooth muscle underneath it. Okay, but a tract, we can assume there's some path. There's traveling going on. Okay, so tract. So keep that in mind. So the ascending tract with an S, so that means there are multiples, but the ascending tracts are going to bring sensory up. Okay, so sensory ascends. Okay, motor descends. So the motor pathway is through that descending tract. Yeah. Now, the names of these tracts, the ascending tracts, again, do you need to know the names of them? Probably not. If you're going to work in neurology, neuroscience as a nurse, maybe you may end up working in like pain management. You may work in physical therapy. You may work in orthopedics or occupational therapy. You may need to know a little bit more about these specifics, but you would learn that on the as you go. I do want to mention, though, that if it is an ascending tract, remember it's going from the spine up to the brain. So when we look at a tract name, it's going to be oftentimes named for the beginning, or the beginning of the structure, and then the end of the structure, where the beginning of the impulse where the impulse starts, where the impulse ends. That's a big clue to whether we're dealing with an ascending tract or descending tract. My point is, ascending tracts ascend from the spine up. So spino is going to be at the beginning of the word if it's an ascending tract. So if I gave you a list of 4 words and said, which of the following is an ascending tract, you want to find the one that says spino and then whatever else. Okay. That's an indicator that it's an ascending tract. It has spino and then some part of the brain. Usually it's the thalamus, spinal thalamic. It could be spinocerebellar. But for the most part, if you see spino something tract, it's an ascending tract because it's spino is where it starts. Okay. And then it would also then be sensory. So then a descending tract is going to have spinal at the end of the word. Okay. So because a descending starts up in the brain or cerebellum, somewhere up here, and it's motor, it descends, goes in the down elevator. So a descending tract is going to end at the spinal cord before it travels out the motor pathway. So notice descending tracts end with spinal every single time. So again, if you're ever given a list of terms on an NCLEX or on a TEAS exam, we're not asking you to know exactly what the cortical spinal, reticulospinal, the tectos vestibular, we're not asking you to know specifically what each of these do. We're asking you to see the terminology giving you the answer. The clue is in the name. Okay. So if it's a descending tract, it means it's ending in the spinal cord. So the end of the word would be spinal. If it's an ascending tract, it's beginning in the spinal cord. So the beginning of the word would be spino something. Okay. Hopefully that kind of makes sense, clears things up. It's not, again, if, on a multiple choice exam, they will throw them in. They may give you this giant three sentence question that's just is asking you which of the following is an ascending tract. And three of your options are going to have spinal at the end of the word. So pick the one with spino at the beginning, or don't pick the ones that have spinal at the end. Okay, ascending, spino is going to be at the beginning. So is spinotectal an ascending tract or a descending tract? It's ascending. It has spino at the beginning. Is rubrospinal a descending or ascending tract? It's got to be descending because it has spinal at the end. So these red ones are descending tracts. So where does the motor pathway go? So these, by the way, are nerve roots out here. These are nerve roots. Notice the motor tracts. Remember, motor goes out the front. Oh, motor goes, almost knocked my light over. Motor goes out the front door. Notice the motors tracts are primarily isolated toward the front of the spinal cord. Sensory, remember, comes in the back door. So we could assume that if these are, for the most part, these are all sensory, we could assume this is a dorsal root or a sensory root. It's coming in the back. So sensory impulses come in this way, get on the elevator. Here's one here, posterior spinocerebellar. So spinothalamic, spino. Okay. These two don't have anything in them. So if all else fails, you do know that all the descendings have spinal at the end. So if you're asked which of the following is an ascending tract, and it doesn't have, none of them have spino at the front, but three of them have spinal at the end, it's like Sesame Street, right? You guys remember that, and some of you probably maybe still watch it if you have kids, or maybe you don't have kids and you just like watching it. But one of these things is not like the other, right? Three of these things are kind of the same. Well, the three things that are kind of the same all end in spinal. So pick the one that doesn't end in spinal and you're good to go if we're talking about an ascending tract. Okay, so that's my Sesame Street PSA for the day. Let's see, how are we doing on time? Boy, it's already 1 o'clock. We've done well. So let's start on Tuesday with the brain. You guys good for the day? You've had plenty to absorb, I'm assuming, right? So. And I don't know if you guys know this. You can give, it might be down on your things. You might be able to give like thumbs ups or clap or thumbs downs, even maybe even a frowny face. I don't know. Do you guys have that capability? I know you can do chat, but does it have like little emojis and stuff that you? But anyway, I don't expect any. I'm just picking on you guys, seeing if you're still awake or anything. Because you know me, I could keep going. I could go till 4 or 5 o'clock this afternoon, and the time would be gone, and I'd look and nobody'd be in the room anymore. So I think I'll wrap it up and let you guys enjoy the rest of your day. do some work and your A&P and whatever other classes you have. And then what we'll do on Tuesday is we're going to really jump right into the brain. We're going to look at some of the divisions of the brain, and then we're going to segue out of the brain and start looking at a little bit of the peripheral nervous system. And then on Thursday, we're going to go into visible body and really kind of take a tour of the brain, take a tour of the spinal cord. We'll look at some nervous tissue a little bit. Okay. Yeah, well, Eduardo, thank you. Eduardo's at least typed his name, so I know he's awake. So you guys are good to go. I'm going to stop sharing, and well, I'll never stop sharing. I like to share, but I mean, I'll stop sharing my screen at the moment. Stop recording. Okay, so.